Welcome, everyone, and thank you for participating in today's event, the Ohio Academy of Family Physicians Breast and Cervical Cancer Screening in Marginalized Populations. I am Erin Yeck, the Director of Education for the Ohio Academy of Family Physicians. The American Cancer Society estimates that more than 43,000 women will die from breast cancer and more than 4,000 women will die from cervical cancer in the United States in 2022. If found early, nearly all breast and cervical cancers can be treated successfully, and that's what we're learning about today. OAFP, in partnership with the Ohio Department of Health, is providing today's webinar for Ohio's family physicians and their practice teams to learn more about breast and cervical cancer guidelines and screenings and programs that can offer assistance, like the Ohio Department of Health's Breast and Cervical Cancer Project, or BCCP. BCCP can financially assist those eligible in Ohio in obtaining breast and cervical cancer screening and diagnostic procedures. In addition, the BCCP's Patient Navigation Program provides guidance in navigating the healthcare system, finding providers and community resources, answering questions about scheduling appointments, using insurance, and more, regardless of eligibility. Joining us today to help us understand breast and cervical cancer screening in marginalized populations is Dr. Heidi Gullett, an associate professor for Case Western Reserve University. Dr. Gullett was born and raised in Youngstown, Ohio. She completed her undergraduate degree in biochemistry and sociology and anthropology at Denison University, her MD at Wright State University, and her MPH in health policy at Portland State University. She completed a combined residency in family medicine, public health, and general preventative medicine at Oregon Health and Science University and is boarded in both specialties as well as lifestyle medicine. She's a former National Health Service Corps scholar and has worked at community health centers for most of her career, including currently practicing at Neighborhood Family Practice on the west side of Cleveland. Her research is heavily focused on addressing structural determinants of health, such as poverty and racism, with a focus on cancer control. For today's session, Dr. Gullett will provide insight to barriers that certain populations face in getting cancer screening, determine what community resources can address the barriers patients face in getting appropriate screening, cite evidence for screening recommendations for various special populations, formulate a plan to address a patient's concerns about screening recommendations. Okay, let's go ahead and get started. Dr. Gullett, I'm going to hand it to you and you can take it away.
Thank you so much, Erin. It's a pleasure to be with everybody today, and I look forward to walking through this really important topic and hearing what questions folks have. So at the end, we'll leave some time so we can have some dialogue and ensure that all questions are answered. So you heard our learning objectives from Erin earlier today. We'll certainly walk through discussing some barriers that certain populations face, and particular focus today on breast and cervical cancer screening, but a lot of those barriers translate to other types of cancer screenings. Determine what community resources can address the barriers that patients face, and the specific focus is on screening. We'll also talk about some evidence for a few special populations, and then throughout the presentation, I've woven some pieces about addressing a plan with regard to patient concerns about screening. That really ties heavily to the barriers and also facilitators. So I don't have any disclosures. I did want to point out today that this is focused very much on the United States. So most of the data that I pulled are for the United States and specifically Ohio. But I want to make it clear that the burden of disease, particularly for cervical cancer and HPV-related disease, is much larger in the rest of the world. And so I just wanted to take a moment to recognize that and say that, you know, what we're doing here is very targeted to the kind of healthcare system that we have and that we as family physicians and our teams practice in, but there's certainly a need elsewhere in the world, and would be a very different conversation around how we manage breast and cervical cancer in some resource limited areas elsewhere. So in getting at our learning objectives, here's a little bit of an agenda. I wanted to give you an idea of kind of what we're going to walk through in order to meet all of those learning objectives. I'm going to talk a bit about the cancer control continuum and some levels of prevention, just for some grounding, making sure also that we have some understanding of shared language, because when we talk about vulnerable populations, we often use language that can be misunderstood. And I want to make sure that we're all using the same understanding today in what we're discussing with regard to screening and disparities around screening. I'm also going to talk a little bit about disparity data with regard to breast and cervical cancer screening and outcomes, just to really help the audience understand the impact of this. And that's been worsened, in particular, the disparities in these two cancers seem to have potentially been impacted in screening during COVID in a negative way. So we have an imperative to address this always, but even now as we are emerging from COVID, an increased imperative. We'll talk a bit about screening barriers and some of their root causes, and talk about some guidance for specific populations. And then talk about applying community resources for screening equity, which is really what we're getting at today, right? We're talking about disparities, but the goal would be that we would create equity around screening access and also around outcomes. And we'll talk specifically about some patient-centered screening discussion pieces as well. So in Ohio, these data come from the Ohio Department of Health, and were just posted in October. And it just gives you a sense that in Ohio, this is an issue for us. You know, breast cancer clearly impacts Ohioans, and it's something that we as family physicians have the ability to detect early and to help people walk through the treatment. But we need to be able to recognize when certain populations are not having the same outcomes. And so that's what we're going to talk a little more about today. This is a cervical cancer data from Ohio as well. And I just wanted to give you a sense that even though the incidence and the mortality seems low in actual numbers, when you think about, you know, nearly 12 million people in our state, and certainly not all of those have a cervix, but there's still, you know, a lot of people. This is still important, and it's still preventable. And so until the incidence and mortality from these cases is zero, we need to continue to have these kind of conversations, in particular because they impact certain populations even more than others. So this is the cancer control continuum, and many of you may have seen this already, but a lot of the information today will bridge from the prior webinar and foreshadow the coming one. It's a series of 3, and my hope today is that this information will build on what you already heard and help transition into talking about actually moving into practice and increasing screening. So the cancer control continuum really starts at on the left side, etiology. And those are those things that really make the risk of cancer, you know, possible. And so sometimes those are genetic factors, and sometimes they're environmental. You can see on the screen, it goes all the way down to health behaviors. For example, you know, people being in a place where there are, you know, iatrogenic chemicals, or, you know, smoking or things like that. When in the case of cervical cancer, we're talking about HPV. That's the infectious agent that's really at that far left side. And we walk all the way through prevention, detection, diagnosis, treatment, and survivorship. And that's the really nice part about the BCCP program, is that, you know, we can use those resources to detect early. I've been a BCC provider in Ohio for more than a decade, and we're able to give that access to people who may not have the access otherwise. But it doesn't stop there, because it's really hard when you screen someone and then you don't have a way to close the loop and ensure that they get all of the rest of the treatment that they need all the way into survivorship. So I wanted to just point this out with, you know, the context of what we're discussing today, because even though we're focused today on detection, which is right in the middle, this whole continuum is really important. The bottom half of this, and this comes from the National Cancer Institute, and you can see the reference I put in the slides for you if you want to look at it more. But you can see that there are cross-cutting areas that go across this continuum. So today we're talking about detection, and we're talking about health disparities, and to a large extent, decision-making. You know, certainly on the individual level, a lot of the barriers really can be ameliorated at the individual level, and we'll talk about that a little more as we move along today. So I just wanted to give you a sense of where we're at today. There's a lot more here that we could talk about, but this is our focus. So early detection through screening works. When people are diagnosed with cancer, whether it be cervical, breast, or other types of cancers late, when it's already spread, when it's a distant disease rather than localized, we know that their 5-year survival is lower. And here you can see lots of different types of malignancies, but these are the most recent data published by the American Cancer Society. Every year they put out information from their surveillance and health equity science teams and give us guidance on what things look like now and how trends have changed. And so you'll see here with breast that if you have local disease, your 5-year survival is really excellent. At distant, it's less than 30%. And if you look at cervical, this has been consistent for many, many years, that if you have localized cervical cancer, 92% survival rate, but it drops precipitously down into the teens for distant disease at diagnosis, and that has not changed for a number of years. So we have two preventable diseases here, and the quality of life that survivors sometimes experience is better when they're having a localized disease treatment rather than a lot of distant treatment as well. So it's not just a mortality issue, but it's also a quality of life issue and survivorship. So the other thing that's really critical when we're talking about vulnerable populations here is that there are social and structural determinants of health that dramatically impact cancer. Back in 1985, the NCI director at that time, Dr. Broder, had said that poverty is a carcinogen. And that is a pretty powerful statement. And we recognize that poverty really impacts people. And we also know that poverty isn't distributed equally. There is an interface of certain conditions and certain structural determinants that come together and change people's opportunity to have access to their full health potential, which includes early screening accessibility. So I want to just take a moment to really recognize that, a lot of times we think of poverty and how it impacts chronic disease or other things, but poverty is a really important factor when we consider cancer. So this is really busy, but I knew you would have the slides to look at, and I thought you might be interested in this. The point of this slide is really to take a framework that is showing you how nested cancer control outcomes are. And so we could take breast, we could take cervical, we could take others. But if you look at it, the quality of cancer care that people get is nested within all of these pieces. So you have a patient, but then you have their family, their social support, and then you have us, the provider team, the clinician team, within oftentimes an organization. I am a family physician who practices in a community health center. So that's the organization in which I provide care. I also work with the health department. So that's the local community environment. And then of course we have state policy, state issues, and that's where I'll from for BCCP. And then also, Caitlin, I'm just stopping for 1 second. I got a notice. Can you hear me okay? Because it said I was, yeah, okay. Great. You can edit that out when you fix it. All of a sudden it looked like I wasn't on. Okay. And then national health level policy is really important. And so today we're really focused on where these yellow arrows are. You'll see I used a lot of yellow arrows to kind of target us in on what we're talking about today, because I want to really help the audience to leave with some very key points, some things that are actionable today, or as you do the third webinar in the series, that you can take a few items here and really try to implement them pretty easily. So today we're going to talk a lot about how that individual patient and that provider team interface, and there are a lot of different dynamics there. The other thing I just want to, just for some quick ground setting here too, is that a lot of times we talk about different levels of prevention, and there are different models for this. This is one of the more newer ones that was recently published last year. But we're in this level of secondary prevention. If you remember that cancer control continuum, today we're talking about detection. Well, detection is the secondary prevention. That's where we know disease has happened. We're trying to catch it as early as possible to create the best outcome we can for that patient. And so I want to just mention that, we're sort of in the middle here. We could have spent time talking about primary prevention, which in this context would be HPV vaccination. So I just want to give you a sense for what that looks like along the prevention continuum too, because what we're doing is really important, but it's not to the exclusion of the other parts of the cancer control continuum or the other elements of prevention. This also may be familiar to many of you. This is a health impact pyramid from the Centers for Disease Control and Prevention. And it gives you an idea of sort of where we have the largest impact when we talk about people's health. And I felt this was important to point out today because we're going to talk a bit about structural determinants of health and how those impact populations to have different breast and cervical cancer outcomes. And so you can see that certainly if we could solve poverty, or we could solve racism that contributes to poverty being concentrated somewhere in the bottom of that period, that would be the biggest impact, right? NCI directors telling us poverty is a carcinogen. If we can tackle that, we can tackle poverty in a really profound way. But that's not so easy, right? And so we're still working on all these other elements. But today we're talking about clinical interventions. Those are the screenings and then subsequent treatment should we find an abnormality that really help people be healthy and not have morbidity and mortality from breast and cervical cancer. I also put this in just for some background. I gave a talk last year at our Comprehensive Cancer Control Annual Disparities Seminar. We do that in the spring every year. And my talk was about disparities and how we see along a continuum what disparities, why do we see them? Why are they happening? And this was a nice article, and I thought you might just like to have it if you want to read more about it. But we certainly see that there are differences in outcomes. Those are the disparities on the bottom. Those are downstream consequences of upstream inequities. So those are problems that we see with bias and discrimination and racism and institutionalized policies that promote those things. So those aren't the things we're tackling in our office day to day, but we have to have enough understanding of how those impact our ability to improve cancer control outcomes in marginalized populations. So that's what this is all about. And you see, I put our nice little yellow arrow again. We're back down at the screening, detection, and diagnosis. So on this continuum, that's where we're at today. And just very briefly, marginalized communities is a term that, I want to make sure that we're using in a way that is understood by everyone. So really, the way I'm using it in this presentation is about historically excluded communities or populations of people who really have had many barriers. And those can be as a result of things like racism and classism, and as a result of discrimination related to immigration status, country of origin, language, religion, gender identity, sexual orientation, and others. So that's what when we use that term today, that's what we're talking about. I also want to just share that when I'm talking about health equity, disparity, and inequities, which I've already used, I just want to make sure that you know what I mean. So health equity, when we achieve that state, it's a place where everyone has a fair and just opportunity to reach their full health potential. And today we're talking about equity in cancer screening. Health disparities are those differences that are linked to things like social and economic disadvantage. And the inequities are more structural. So things that are systematic, avoidable, and unjust. And so we're going to talk a bit about how some of those barriers that we see in these populations we're discussing today come from those structural issues, from those inequities, and what do we do about that in our context? This is just another way to look at equity and equality. This comes from Robert Wood Johnson Foundation, and it's basically meeting people where they're at and giving them what they need at that moment. And for me, addressing barriers in cancer control and screening is about meeting people where they're at and ensuring that we're providing what they need at that time. And that could be individual resources. It could be a conversation about misinformation that they've heard or concerns or fear that they have. And so that's really what this is about. If we just had a one-size-fits-all approach to doing cancer screening, that doesn't work for all populations. And so you can see it's, here very, very concretely, the size of the bike and the type of bike doesn't work for everyone. Same is true when we think about any type of healthcare intervention, including cancer screening. And then finally, social determinants of health. At this point, we've all heard them. We know what they are. But I wanted to add that structural determinants of health are a little bit more upstream, and those are those political and economic and social policies and organizations' infrastructure that do create the inequalities that we often see come out like social determinants of health. So lack of transportation, housing, food, insecurity, and the things that we often encounter in our clinical practices every day that lead people to not have a healthy context to live in. And then finally, an important piece of talking about addressing barriers with patients is cultural humility. When I trained, we called it cultural competence. And it's really important in the medical education space that we're moving from sole discussion of cultural competence, because that sort of insinuates you've arrived, that you're competent. Cultural humility is the way to focus. And that is, this is about an interpersonal stance that allows you to continually grow and continually understand the cultural identities of other folks and really do that in a way that's really a way of living, a way of practicing medicine. So that's going to be an important definition when we get a little bit more to barriers and facilitating conversations with patients in the latter part of the talk. So I gave you some data here around cancer disparities, just talking about what we see. We know that early stage diagnosis of cancer that is a result of screening differs in some racial groups. And in particular, we know that people who identify as Black have a higher risk of late stage diagnosis of cancer that had recommended screening. So that means that people are not necessarily getting those screenings. They're being diagnosed at a later stage. And you saw the earlier data I presented that when people get diagnosed later, their 5-year survival is worse. And if people need more aggressive management of a malignancy, then that may contribute to challenges with survivorship and quality of life. So I know that we all know this is a problem, but I wanted to give you some concrete information around the latest cancer disparities report. And this one particular comes from the American Cancer Society. These come from their most recent report, and it's a comparison of looking, I pulled the two that were referenced for today, most relevant, were breast cancer screening, so no mammography, and then also cervical cancer screening, so no pap testing. And these were women 50 to 74 who did not receive a mammogram in the prior 2 years that were tested. So that's 2012 and 2020. And they're listed by race and ethnicity. And if you see here, you'll see that there were lower rates of screening in that earlier year, which is interesting because we were in COVID in 2020. But you'll see that there's an asterisk by Black and American Indian and Alaska Native, AIAN. Both of those are statistically significant differences in screening as compared to their white counterparts. So clearly an issue with disparities in the actual screening that occurs. This is the same information with regard to cervical cancer screening. And in this case, you'll see that the differences are also in people of color, Black, but also Hispanic and Asian. And the other piece here, and I really foreshadowed at the very beginning, is that, screening disparities have long existed, and they have existed prior to COVID. But what we know is disparities in a lot of health outcomes and health access, such as screening, were reduced during COVID-19. So while this has always been urgent, COVID-19 has really given us a new sense of urgency that we're going to have people diagnosed at much later stages if we are not aggressive about getting people in for screening, and particularly those that are historically marginalized or vulnerable. These are the outcomes that relate to both breast cancer, and the next slide will be cervical cancer. I just wanted to show you with regard to a racial and ethnic breakdown. These are also how people self-identify. I wanted to make that important point today too. It's important that you have people self-identify rather than assuming what someone might, what population they might be in. And so that's an important piece when you're looking at your own clinical data and your own practice, but also data like these. You want to know how they were collected and how people were classified in the information. So this just shows you that actually when you look at incidence, we're seeing pretty similar incidences with many of the groups of color, but when you look at mortality, it's significantly different for, in particular, non-Hispanic Black individuals. So a much higher rate of mortality as compared with the actual incidence. And this is all incidence. This is localized all the way to distant metastases at diagnosis. So that's an important thing to realize here. And then for cervical cancer outcomes, you'll see that there's clearly a difference in mortality, and that in particular is with American Indian, Alaska Native, and non-Hispanic Black individuals. So again, this continues to make the case for why this ability to get focused on populations which experience health disparities is really important. So cancer screening is a process, right? I think most of the people listening to this, you know this process inside and out, right? There's a whole individual piece of this where your patient needs to understand the utility of such a test. Why would I even entertain that? And then they have to agree to it. The order has to be placed if it's not done in your office. If it's done in your office, you're still collecting a PAP and you're still sending it in, so the order has to be done. If it's done outside, they have to arrive at a screening location, oftentimes at a specified time. They have to physically complete the test. The result has to go back to someone in the practice who was ordering it, and then management of abnormal results. So this is very self-explanatory, but I walked through those because there are barriers every step of the way. And so a lot of times when we've done the quality improvement and cancer control workshops and days with the OAFP, we focus on a lot of these different leverage points for quality improvement. And so I just wanted to highlight again today that the barriers for marginalized populations exist in all of these places as well. So multi-level approaches are needed. There clearly are individual approaches, which are really important. Clinicians have to have knowledge of evidence and skills in cultural humility to be able to facilitate those conversations. There are often patient resource needs that approach many of those touch points, right? They have to come to the office. They have to get to another location for a mammogram if you don't have that in your office, things like that. So transportation and other physical resources needed to complete the screening. There also needs to be an identification and stratification of risk for that individual patient. And that's a pretty clinical thing. It can be done by a team, but that has to really be done on an individual basis. So what are people's sexual organs at birth? Is that a question you're asking? Are you asking about genetic risk, particularly for breast cancer? The microsystem of care, in this case, I'm really talking about the office, and the system facilitators are really office-based for orders. So do you have standing orders and things like that? But also result follow-up. Are you able to identify insurance coverage at the time of visit and link people with uninsured coverage? You know, the EHR, the electronic health record tools, there are a lot of provider prompts. There are a lot of ways that we can be reminded, but if the data in the system are wrong, those reminders won't be accurate either. So there's some effort there. Clinician assessment and feedback is really important as well, along with patient and practice screening data. And then of course, plan, do, study, act improvement cycles. All of that's really at that microsystem. And then at the macro system, policy around health insurance, a culture in your local community, in our state community, or in our national community around valuing prevention. Those are all big picture things. There are many others as well, but I wanted to give you a sense for the multiple places where we could intervene. And I really want to spend the rest of our time thinking about what we can do in that individual and microsystem way. So there are a number of published reports, peer-reviewed reports about facilitators of cancer screening, and not specific necessarily to breast and cervical, but cancer screenings across the board. So that's really that early detection on the cancer control continuum, and that's the secondary prevention. When we talk about prevention, those are the screenings, primary being HPV vaccine, other vaccines, hepatitis B for liver cancer and things like that. So we know that these are really important. Facilitators meaning things that make it more possible. So health insurance, clinician recommendation in the context of a trusted relationship. That's a really important caveat. Shared decision-making with the clinician. Perceptions of cancer screening. Gender differences in screening behaviors and norms. Geographic location. And future orientation. And the future orientation piece comes from research that I've been doing that's been funded by the American Cancer Society on understanding how do they prioritize screening or cancer control activities like smoking cessation when you're really focused on the here and the now. You're focused on the here and the moment. And it's really hard to think about things in the future. Such as a cancer developing when you're really focused on things like food security and transportation and job security and other things like that. So I'll talk a bit more about that later, but we certainly know that these are facilitators of cancer screening. Some barriers are a lack of all the things on the previous slide. So I won't read those to you again, but barriers certainly are not having any of those things, or one or two of those. Social determinants of health, so things like transportation. Barriers can also be inconvenient, especially, for example, with our patients, my office, all of our offices in my clinical practice are on the west side. If they need to get to a cancer screening test on the east side, it's not going to happen. It's not going to be feasible. So that's a really important thing. Beliefs about cancer are also really important. Sometimes there are personal beliefs about cancer or about the screening test. Sometimes there are familial beliefs. Remember, I showed you that NCI nested diagram of understanding how people make decisions about their cancer care, including screening. Sometimes it's the way they interact with the clinician and the provider, and they have beliefs that they don't feel comfortable telling the provider about that might impact their willingness to do a screening test. Misinformation is rampant. We've learned this with COVID and COVID in the era of social media, but it doesn't stop at COVID. Certainly, it also is true with regard to lots of cancer care. Misinformation about available options. I often have people tell me they decline getting a mammogram or they don't want to do a pap test with me because they don't know what would happen if it was positive and they don't have insurance, or they don't think that they'd be able to get through the what happens next piece. And so that's a really important thing to uncover, because that's why BCCP exists. That's why other supports exist, which I have on later slides, to make sure people know they're not alone, and they'll have guidance through that. Mistrust of clinicians in the health system. There are a lot of really important reasons for mistrust of clinicians in the health system. We certainly have seen that in COVID with lots of different groups, lots of different demographic populations. But in particular with people of color, there are a lot of historical reasons why they may not trust the health system or individual clinicians. And in fact, there are still lots of examples of bias and racism in direct individual care, as well as in health systems. So it's both historical and contemporary injustices around this that make a mistrust a real barrier to screening in many cases. And then complexity of the healthcare system and individual fear about lots of different pieces of this. Reducing barriers. So here are some pragmatic starting points. This actually comes, these are some I added in from other resources, but most of them come from what's called Screen Out Cancer, which is a nice resource that the Centers for Disease Control and Prevention offers. It's free, it's on their website. But some of the real practical starting points are prioritizing cancer screenings in your clinical practice. If you don't look at focus on cancer prevention, and it's something that your practice is going to focus on, or you as a clinician are going to focus on, it will get drowned out by all the other more pressing things that happen. So
Dr. Gullett, I'm sorry to interrupt.
Important is a way to really move the needle. Proactive population-based outreach. So it shouldn't just be about individual patients on the day they come for another visit, getting a mammogram order or asking when they want to schedule their PAP, but actually looking more at your whole patient panel and having outreach around what's proactive and what part of the population isn't being reached and why, and not just waiting for that really reactive, they're here now, I'll give them an order and hope they get there. That's still, you can do that, but proactive population-based outreach is really a great starting point. Transportation assistance is really important. Flexible hours, so working with imaging places for flexible hours, more locations. That is a picture of the mammogram van that comes to my clinical practice every month, I think now several times a month. And when we didn't have that, it was hard, but now we actively schedule patients, but then when they're also there for some other reason, I also pull them outside and give them a mammogram while they're there. And it's been wonderful. Some women who have never had them before have had them because we had the bus outside. Less paperwork. So if you make it complicated and cumbersome, I myself as a patient don't like to deal with that. Standing orders are really great, right? Those are great places to start. It doesn't have to be you as the clinician writing a new standing order. And then patient navigation, particularly when you have an adverse screening result. So patient navigation can be really, really helpful. And you don't have to do that all yourself. This is about bringing resources together and building capacity across the community to do this. So here are some implementation tools for clinicians. I did not put specific guidelines for breast and cervical cancer in general guidelines today. You had that in the first webinar in the series. I do have some very specific ones at the end for special populations, but you can find them and they're here, and I would encourage you to look at them on a regular basis because they get updated. For breast, it's the U.S. Preventive Service Task Force, as well as the American Cancer Society and the American College of Obstetrics and Gynecology. For cervical cancer, it's the USPSTF again, but also ASCCP, which is really the national body that gives us the cervical cancer guidance. And I've been a longtime member of ASCCP because I do a lot of women's health in my clinical practice. And I do a lot of cervical cancer screening in the form of PAPs, and HPV testing, but I also have done colposcopy for many, many years and did LEAP for a number of years. So for me, it's really important to have what I feel are evidence-based guidance. So that's why I gave you these if you're not familiar. There are a lot of others too, but these are the ones that, that I most closely use. There's also an app if you want to get that, which makes managing PAP testing results very easy. It just tells you what to do. And then training and cultural humility is really important. And they give you tools for inclusive patient-centered care. There are a number of online courses you can take. There are a number of in-person courses now post-COVID that seem to be emerging again. And also courses in diversity, equity, and inclusion. That's really important when we think about meeting the needs of marginalized and vulnerable populations and ensuring that we are focused on health equity with regard to screening and outcomes for cancer care. And what those trainings do a lot of times is give people an understanding of history, bias, the roots of mistrust in healthcare, and tools for allyship so that while we're practicing medicine, we can ensure that we're using inclusivity and reducing bias as much as possible to help our patients get their best health outcomes. And then these are also tools for clinicians and practices. So there's the CDC has a guide on reducing structural barriers to cancer screening on their website. That's in the same area of the website as the Screen Out Cancer information. They also have a number of evidence-based intervention planning guides, and this is something that you could think about looking at prior to the next webinar, which will jump more into quality improvement and thinking about implementation. In those are patient reminders, reducing the structural barriers that they talk about in that guide, clinical reminders, and how to assess clinicians and their feedback. There's also a nice toolkit on the National Colorectal Cancer Roundtable that has risk assessment specific for colorectal, but their screening toolkit really can be adapted to breast and cervical. And I've actually used it in my own practice for breast and cervical adaptation screening improvements. So I would encourage you to take a look at that. I have the resource at the very bottom of the page. And then the American Cancer Society has excellent toolkits. They have one specific for community health centers. And a lot of them are focused around colorectal because that's where they piloted the information. But just like the National Colorectal Roundtable, you can also adapt those for breast and cervical. So it really takes a community of support, a village, to ensure that we're getting everyone screened. And so I put here a lot of different places where you can get support. Public health is really near and dear to my heart. I'm a public health doc, work with the health department up here in Cuyahoga County. But I don't think a lot of times in my clinical training, I realized how much it would help me to interface with my local public health colleagues. So at the local health department, get to know your local health department. They're probably the ones administering, not just for breast cancer, but others. Certainly we're going to hear from Dawn at Ohio Department of Health colleague about BCCP, but they have 4 other state cancer control programs. If you're interested in learning about them, they're on the ODH website. And then federal, that is an alphabet soup of algorithms, and I could not possibly write them out because it would have taken my entire slide. But my point in showing you these is that at every level of public health, there are focuses on both individual care and needed resources for screening and population level focus on getting policies and systems and structures changed so we reduce those disparities in cancer outcomes. There are also a ton of not-for-profit and philanthropic organizations. And so it's going to depend on your context, where you live in the state of Ohio. For me, I'm here in Greater Cleveland. And so I have a lot of different organizations than you might have in another part of the state. But I wanted to give you some examples so that you could kind of be thinking about your own context and who you might link with. Non-clinical advocacy groups are awesome. We've worked a lot with community health worker organizations, a lot of grassroots neighborhood organizing groups here in Cleveland, and that's a great place to develop partnerships with trusted community ambassadors. There are also a lot of clinical entities that could be a health system, a larger health system, but oftentimes have some patient navigation, may be able to meet patients without resources, and whether it's through BCCP or their own community benefit programs, which they often have. Community-based research is important too. I threw that in because I provided a little bit of some of the cancer control research that I'm doing around how we work with people on an individual basis living in poverty to overcome some of those barriers around having a focus on the future which is necessary to actually do cancer control screening. And then professional organizations, our own OAFP, but also the ones I mentioned earlier around some evidence. And then cancer-focused specific ones. So we have Komen, American Cancer Society, and many others. And they often have individual opportunities, pools of funds for individual resources, transportation, other things that people may need for survivorship, but also, give you support as a practice for what you might need to have practice change. And that's what this series really is all about. And I put this in not to have you read all of this, but to tell you that we have for a long time had 10 essential services of public health, and that includes linking people, individuals, to needed health services. A big part of that is cancer screenings, and a lot of health departments do cancer screenings. So see what they have to offer. We here in Cuyahoga County have a program where we do cancer screenings for cervical cancer. So, it's important that you know what the public health department does, but there's a partnership opportunity as well. Very specific populations in our last few minutes together, I'm going to run through. There are a lot of different populations here. This is certainly not an exclusive list, but a few that I wanted to just mention during our time together. So with regard to the LGBTQ plus community, the American Cancer Society actually funds an entire area of research on improving cancer screening rates and also cancer outcomes in the LGBTQ plus community. And so this is some recent evidence from one of their researchers, Dr. Charlton, that you see at the bottom there. And it really is clear that LGBTQ plus community members really do not necessarily get encouraged to get screenings at the same rate. They're less likely sometimes to get cancer preventive testing, particularly if we know women who identify as same-sex often don't get offered Pap testing, don't get offered HPV testing, HPV vaccinations. And that's the doctor or the clinician making an assumption about risk without necessarily talking to that individual patient. So it's really, really important to have those conversations, and that can only happen in a trusting relationship. So a lot of times in the clinical world, we center, heterosexual, cisgender, normative ways, and that really cannot be the way that we're going to get to equity around cancer screening, particularly for this part of our community. Specifically about mammogram, Black heterosexual women is the comparison group here, and Black bisexual women were more likely than to have had a mammogram in the last year. And Black bisexual women had the highest prevalence of having a mammogram. So there are clearly some really good success stories here, but I wanted to make sure that I highlighted the importance of the research and the data around this, because otherwise we just use assumptions around how we're meeting population needs in very specific groups. I also want to talk a little bit about newcomers. That's a term we often use for different populations, newly arrived, people who have a country of origin other than the United States, more recently immigrated here, many who come through the refugee program. In my clinical practice, we see a lot of people who are in the federal refugee program. And it's important that we recognize that those women do not get screened for breast cancer and for cervical cancer at nearly the same rates as their English and Spanish speaking counterparts in the same practices. This is a study that I did with one of our residents a few years ago. And you'll see that in our own practice, we had a much lower rate of Arabic speaking female refugees who did not get their cervical cancer screening. So this was a really important project for us to identify that we were missing not just the refugee population in general, but specific Arabic speaking women. And this is just a sample of what some of the qualitative data can look like in these kind of quality improvement projects and practices. We asked about barriers and facilitators, and here's what we found, right? That patients felt supported by the team, and so they wanted to do it. But there were sometimes a fear of cancer and a fear of, if you look for it, then it's going to come. And so it's important to really dive into understanding people's thoughts about cancer and about the screening test sometimes. Sometimes it's a black box if they've never been around that screening test before and they've heard what it's like or it's really painful. Facilitators really were, the physician or clinician recommending it. Family history was definitely a strong motivator, and also the gender of the provider is really important. And I have that in a final slide as a key. I also wanted to highlight disability status briefly. We know that women with disability often and it's really important that we think about disability status as an important population in order to focus more specifically on. I really wanted to touch on screening evidence for breast cancer in men. That was a specific thing that we wanted to cover today with our ODH partners. So I put in here some national organizations that have different recommendations for screening men who are at high risk for breast cancer. I want to be clear that there is no image guidance for imaging right now. So that's something that there's certainly been some recent publications about. In fact, the publication I included here is a more recent one from 2020, but you can see that there are no recommendations for a number of our professional organizations. And most of the other recommendations are for those who are BRCA2 positive, which is a higher risk than BRCA1, but that's also a risk. So there's some breast self-training, but most of the time when men get diagnosed with breast cancer, it's late stage because there is no screening. This is a risk of, it's the relative risk, these data are relative risk of malignancy, but you'll see the different genetic mutations, age, and several other demographics, and then some with different hormonal issues here. And we certainly know that we have a very high level of prevalence of obesity in our communities across the country, but also in Ohio. So we can't ignore that, but we don't have good evidence right now about a screening recommendation for men. About 1% of breast cancers right now are diagnosed in men. So certainly it's low and relatively rare, but it's important to still consider as a special population. And then these are some benefits and drawbacks of image-based screening. And I just threw this in here to kind of, it's not as easy as just doing a study and saying, okay, should we screen, right? You've seen a lot of changes over the years in breast cancer screening recommendations for women. And so, this is not necessarily an easy thing to do, but when you think about your screening and talking to your men who are at high risk, maybe have some of those conditions on the previous slide, I wanted you to think about what the imaging benefits and drawbacks were. All right, so in the final few minutes before we move to questions, there are some considerations for some patient-centered screening, and these come from lots of different resources and also my clinical experience over the years. But it's essential to prepare a patient for what they're going to expect. So, if it's a patient with a disability, a physical disability in a wheelchair, if it's a patient who has a cognitive disability, you really need to prepare them for what they're going to experience, because the healthcare system is very unforgiving in my own personal experience as a patient. I know what to expect and I still find it very unforgiving. And so I really try to prepare patients. I have a lot of non-English, non-Spanish speaking patients, so ensuring language services are provided is critical. If entities are receiving Medicaid and Medicare and anything from CMS, they are required to give language services, but that doesn't always happen in practice. So really an important piece. Use of inclusive language. This is new for a lot of clinicians. Instead of saying a woman or a man, I've used that language during our talk today, and I really hesitated about whether I should talk about inclusive language at the beginning. And I went ahead and talked about it as woman, man, but we need to think about using inclusive language, a person with a cervix. If we have somebody who identifies as non-binary but has a cervix, we need to be sure that they're welcome in our practices and that we also meet them with any screening that they are eligible for. And then foster a context in which a patient is in control of the screening experience. This is really important in a number of groups, particularly for women who are sexual assault survivors. I often use a technique around allowing them control of the speculum insertion. Honoring a request for female clinicians. I'm not saying that because I'm a female clinician, but I have a lot of patients in my practice culturally who would not see a man, and we need to honor that. So these are a few considerations for certain groups. So I just have some final high-level take-home points. Certainly, there is much more we could cover across the different types of cancer control continuum, but hopefully you got some nuggets today on the screening side. Multi-level approaches are necessary to address different barriers at different parts of the screening process, but don't let that be overwhelming. It doesn't have to be perfect. Just start somewhere. You don't have to overhaul, just start somewhere. individual and community trust are essential for this process. If people don't think you care, they're not going to hear what you say. And so you've got to develop that trust. And that's what we do as clinical teams. But sometimes we're also not cognizant of the long history of injustice that people who come to our practices have experienced, either personally or intergenerationally. So building trust and understanding that context is really important. And it's earned over time by being intentional and understanding, what some of these issues are. Accessibility is important. Bring that screening van to the neighborhood. That's really key. Or help people with transportation if that's not possible. Help folks with obtaining insurance if possible, because we do know that health insurance is a huge link to actually getting screening completed. Partnership with trusted ambassadors in the community. If you have community health worker neighbors or other partners that are trusted in the neighborhood, that come from the neighborhood, that's often a great way to get people to think about screenings they might have been resistant to do in the past. Befriend your local health department. I talked a lot about how they can help you, but they are your friend. Clinician recommendations can make a huge difference. So don't forget to do that. Yes, do outreach. Yes, have your team ask them. Yes, it shouldn't all be on you. But when you recommend it, even in a split second, hey, I recommend you get that mammogram they gave you an order for. That actually makes a big difference. And there's a lot of evidence to show that. Ensure folks are up to date with knowledge on cancer screening recommendations. So we as clinicians have all this information coming at us about all sorts of conditions, especially the generalists that we are. So making sure that you know where to go for the latest recommendations. And I would recommend at least with some regularity, you look at those, whether it's once a year or every 2 years, just to make sure you know what the recommendations are. And then consider the impact of future paradigm on screening and also on health behavior counseling. So time horizon is sort of what you're thinking about. And, I, as a clinician, I'm thinking about today, this moment right now, I have to finish this talk on time, right? That's my moment, right? But I'm also thinking about next week, a few years from now. I have a retirement account, so that means my time horizon is probably a couple decades from now. And for many of my patients, that time horizon is in minutes or hours. And so we've been piloting some work here with an anti-poverty program called Getting Ahead, where patients have time to think about their future. And we have seen a statistically significant change in time horizon from those few hours and days to actually thinking more weeks and years. And that's key to getting people to think about why they want to quit smoking. Why should I get a pap test or a mammogram? They don't think they're going to be alive. Why do it? But if we change that future time horizon and a future paradigm, it can help. So with that, I thank you so much for your time. I think we probably have a few Q&A. I see them at the top of the screen. So I'll pass it back to Erin for just a minute.
Thank you, Dr. Gullett. I really appreciate you going through all of that information. Really, in the interest of time, I'll let you go ahead and jump into questions. It seems like we have a few. If you're able to find those on your screen and run through them, and I'll clear them for you once you get through them. I
have. So Dr. Winslow, who trained me several decades ago, it's near and dear to my heart, Dr. Winslow. He says that he's heard much discussion about the disparities experienced by patients with disabilities, including functional disabilities, physical, and the IDD population. Can you comment on the need to take an equity approach to addressing this population and their special needs and how to improve our outcomes? Yeah, absolutely. And that's one of the reasons I put it in as a specific population. It's hard to say people with disabilities, this is how you approach it, because disabilities is a huge heterogeneous category that we label a lot of people with. But I think it's really important to think about the specific disability. Is it cognitive? Is it functional, physical? What is it? And then ensure that there's accessibility meeting the needs of those folks. And that can only happen with an equity-based approach. You can't give everyone the same kind and size of bicycle and expect that it's going to work, going back to that concrete metaphor from the beginning. But we don't often think about patients who live with disabilities as a group where we need an equity-based approach. And I would argue that we really do. But it's got to be tailored to that group. I'm the primary care doc for a number of nonverbal women who live in a group home. Some are in wheelchairs, some are not. And we've had a lot of discussion about breast cancer screening, and one of them actually ended up with breast cancer. And so talking through with those caregivers and those decision makers about what do we do with these decisions and making sure they understand that's really, really important. there's a comment about the concept of cultural humility as opposed to cultural competence and cultural awareness. Thank you so much. I'm glad that that was useful. And there's another comment about adding LGBTQ community to Ted Winslow's list. I don't know if that's the list from the top, but maybe there might be another Dr. Winslow question I don't see yet. Let's see. So what can practices do to increase the understanding of the need for cancer screening and other prevention best practices in the communities we serve? We see within the four walls of our office a very small time compared to their time out in the community. How do we best accelerate our communities developing a culture of health that reinforces our health messages to our patients wherever they go in that community? Any good examples in Cleveland of activities to engage and educate the broader community toward a better understanding of how to achieve better health? Yeah, thanks, Dr. Winslow. So that's a really good question. It's a complicated question, certainly not easy to answer, but really important. And I think culture of health is a term coined by Robert Wood Johnson Foundation. And actually that, what I showed earlier on the equity and equality slide comes from some of their culture of health publications. But it's really important that we recognize how holistic that is. And using people in the community, ambassadors in the community, is an example of what we've done here to foster that notion of culture of health. So there's an amazing community health worker organization up here called A Vision of Change, and Misty is the founder and director, and she's gotten a lot of different community health workers now working in her team, but they have done a lot of work around chronic disease. They all became chronic disease self-management trained. But what's interesting is when COVID hit, her team pivoted to focus on COVID within an understanding of a culture of health. So health is this holistic way we view things spiritually, physically, emotionally, and that's the way she approaches everything. But she said, it's important for us to partner with the health department around COVID because our people are not getting screened, they're not getting vaccinated. So she worked with folks to create a toolkit and disseminate that in the community so that people on the ground could actually make those impacts. So I think that's an example of engaging and educating the broader community about that. But there are a lot of different levels on which we really need to tackle this, including policy, which we don't have time to talk about today, but we could talk about it another time. And then I know we're almost at time. So I'm going to hand it back to you, Erin, because I think Dawn needs a moment to talk. But I'm happy to talk with anyone. My email's on the screen and happy to answer other questions. And I'll take a look at the ones that are on the screen as well.
Absolutely. You can even type in there if it's something that you think you have some time to answer that way. So thank you to everyone. I hope you enjoyed this session. I know we covered a lot of material. I hope you find it useful for your practice setting. If you're interested in learning more about the Ohio Department of Health's BCCP program, I'd like to take a few minutes just quickly to introduce Dawn with ODH so she can tell us a little bit about BCCP.
Hi, thank you. And the presentation was really great. I do want to mention that the Ohio Department of Health, the Breast and Cervical Cancer Project, is a project in the state that helps to pay for breast and cervical cancer screening for women. We do have eligibility criteria at 300% of the federal poverty level and below. We do help women who have insurance as a secondary payer, and also those who are uninsured. We have a lot of projects, and just in the conversation that was happening discussing about community health workers, we currently have a community health worker grant that is eligible right now for applicants. So I urge you to visit not only the BCCP website, but also the ODH grant website and look at the community health worker grant that we have posted. If you have any questions about either becoming a provider for the Breast and Cervical Cancer Project or how to enroll women in the Breast and Cervical Cancer Project, please send us an email. It's bccp@odh.ohio.gov. You can also go to our website and gain some additional information.
Thank you, Dawn. I appreciate that. So again, thank you for joining us on behalf of the Academy's leadership and staff. We hope that we have provided valuable education. Thank you for all that you do to advance health in your communities. Keep up the dedicated work. We appreciate it. Thank you.